I was gonna bug Drew instead of you, but he's mad because he didn't have.
Yeah, she's good by now. She's gonna die. So she's actually your doctor. Just as good. No, we're all here.
I like that podcast. Yeah.
What time is your? I'm right out.
Frank, I feel really bad. I had two. Mike took them all.
I know they changed it now to make it look like an important document.
Hey, Bill.
Oh, I don't.
This chair is over. Okay.
Yeah. I don't know.
Maybe it's 60.
I don't know, but
I had a guy who's got CVID. He's like 45 years old. Children.
yeah, but
Suzanne still sees old people.
Yeah.
I saw one of her 45-year-old CVID. The oldest person in clinic you guys find. She still sees them. But it's funny because his daughter came in and she's probably had these recurring infections. And I said, when I get her cats, I'm getting her blood, and he goes, so she came in for allergy.
I had a really set up in December.
I said, do you really want to CAT scan this? And I told me to say, you hit her about
so that's why I came
I already know Suzanne, so she's still here. How long she has? Still running up?
Yeah, I mean, she knows there's priorities. Yeah.
He's 70 something. He's still running up. We're recruiting Mike back.
Maybe the brain.
kind of like that.
How long will be the oldest person? Oh. That kind of change.
I don't know.
Everything is happening right now. Everything we've been waiting for 30 years is happening right now. I want to desensitize one kid to chemo. I want to desensitize one child, and I can until that happens. I want
Yeah.
Yeah, we used to take people and take spectral methods to get here, put a baby that has asthma and stick it up your nose.
Okay, well, I just sent you.
I finally convinced Regents that her
So you guys are out. Oh, is that university?
then they find out before then they would just avoid all that. So I had your life.
Yeah, she's going to be one
So now they let me take it.
No, I know. Well, it's so Steve.
Yeah, it's the green with the same.
I think that's the fair that
Yeah.
Our presentation on there is
Yeah.
I'm trying to see if we can get them on your computer.
Yeah, I would like to get oh, can you make it today? 6 o'clock. Did you get that from this one candidate?
You didn't come.
Oh. Can you squeeze get 6 o'clock? It's right there. It's right there at the next
Well, no.
Is that a Mac?
He's trying to get it off his.
Just separately because we've already set that up, Drew.
That's a
Better
power.
than me.
Yeah.
Alex, do you have a Mac connector? I do not. Sorry. I only run Android.
That's why years, not here.
For those of you who are waiting for this presentation on the outside, we're struggling, but hope to have it together in a minute or two. Anybody got a joke to tell or news to? Don't tell Drew how invaluable he is in setting this up, that he takes a day off and we're screwed.
Do you appear on the line? Is there a lifeline call?
We called him a couple of times. I don't know where he is, but I woke him up about 45 minutes ago.
Oh, okay. He's at test on KDH. You guys just want a USB stick?
No.
Could Travis be in, or?
He knocked on the door. He's not there. I don't think he's here.
You just go upstairs to one of the labs and grab one of the shit.
Oh, Francis. I don't know if we should hold you up any longer and let you get started. Because everybody got these slides by email last week. I think we just go.
I have never had to do this here. Average time something that's totally good.
They seem to make the system particularly hard.
Yeah.
You'd think they should just have a way to plug in your laptop and go.
We all have the input on.
Yeah. Now the PC world is struggling because everybody wants everything on their phones now. They don't want it on a computer anymore. They all want it on their phone.
So, interesting place that you decided that's what it was.
Multiple different yes. Presentation. Yeah, exactly. Yeah, unfortunately, I won't be able to make it to the production. Everybody else, of course.
Well, at least you got the handout. Remember, it's the birthplace of last year.
Turn the page.
Not down on the water.
Yeah, it is. Yeah, if you want. You own the whole peninsula. We own that. Yeah, you can smell the cinnamon and sugar and one of the donuts to be there. I finally bought them at the shop down. Couldn't do that anymore.
You know, there's a special flour for making donuts. You have to get donut flour.
Stop it.
No, it's not just regular wheat. They have donut flour. I don't know what's the difference.
Is it like cake flour?
It's halfway in between regular wheat flour and cake flour.
Okay.
But we were watching a thing on how to make apple fritters because that's the thing in my family is apple fritters.
Okay.
My daughter figured out when they're on sale, she buys a dozen and she freezes 8 of them. And then she has apple fritters like a couple times a week. So it's like when you're young and skinny, you can do that kind of stuff.
Well, let me think.
We tried to
Not
make
young,
them.
not skinny.
And you lay it out like pizza dough, and then you run the apple stuff on top of it, then you just roll it up and you slice it with your cleavers. And then you throw it in the oil, which is the disgusting part.
Oh, no, that's...
There's healthy oil, there's less healthy oil. There's less healthy oil than healthy oil.
Yeah, that's right.
That oil is 9.4 calories per gram, whether it's healthy or not. So, but anyway, so we made our own apple fritters, which are actually probably good. It's like a huge amount of effort. But to find donut flour took us quite a while to actually find donut flour, so they bought it on Amazon.
I had no idea. Yeah, Amazon's got it.
Pretty much.
Yeah.
But it was interesting.
Donut flour.
Donut flour, yeah. And then you can buy the apples and cut into like quarter-inch pieces. It's not applesauce. It's like it's like little tiny pieces, and you just spread it out like you would spaghetti sauce.
All right, well, I don't want to hold up our guest speaker any longer. Technology is great when it works and frustrating when it doesn't. Anyway, I'm not going to waste my time with introductions. Just thank Bacharier for coming to town and putting up with this ineptitude of trying to put together a presentation. If we have an outside audience or listening, hopefully you got the presentation sent to you last week so you can follow along. So thank you. We'll belatedly let you get started on severe asthma in children.
Good morning. Thank you for the introduction. I never hold technical issues against anyone because it's just part of what we try to do. We're trying to share this with off-site people, and those best efforts sometimes don't go rewarded as they should. Hopefully folks have a hard copy of what we're going to go through. I'm glad we have that. So why don't we just launch in? I'm going to talk about issues related to how we think about severe asthma in children, some about diagnostic issues, some about some of the work we've done as part of the severe asthma research program that's really taught us a bit about the underlying physiology and biology of the disease, and then a little bit of a discussion around therapeutics. But that's really the smallest part of the discussion.
Do you at least see your own presentation?
I do now. All right, so my disclosures are there. I'll let you decide. I clearly own no stock in any computer or internet file sharing companies. So, when we talk about severe asthma, the first thing we have to do is try to define it. There are multiple definitions, none that are universally agreed upon. They're all a little different. It's peculiar in that our definitions of severe asthma in general are based on the amount of therapy it takes to either control the disease or not control the disease. doesn't actually define the disease, but rather the amount of therapy, and it's usually what we call step 4 to 5 care. Really, it's medium to high dose ICS with LABA, with or without an additional controller.
I have a presentation here.
I have it up there.
Oh, okay. Okay, the broadcast. Okay.
So, moving on. So, childhood asthma, when we think of it, really is you can think of severe asthma in 2 general buckets. Severe asthma that you can control pretty well, and severe asthma that you can't. Difficult to control, difficult to treat. And I think it's really important that we understand and maintain recognition of that distinction, because non-adherent asthma might not really be as severe as it seems, right? It may be that had they taken appropriate therapy, it would have been pretty manageable. But without appropriate therapy, we're limited, and our patients don't do as well. And the way we approach the difficult-to-treat asthmatic is different than how we might approach the truly severe asthmatic. And when we think about that difficult-to-treat group, why might a patient be difficult to treat? Well, it might be because they don't actually have asthma, that the diagnosis is incorrect. You need to think of an alternative that better explains their disease. There may be a complicating factor that could include comorbid disease, could include poor drug delivery, or it may represent true severe therapy-resistant disease. So, as we think about severe asthma, data from SARP reminds us that in children, severe asthma looks different for each child. There are children whose disease is manifest by daily symptoms. There are children whose disease is manifest by frequent exacerbations. There are those who are manifest by low lung function and persistent airflow limitation. And there are some who demonstrate persistently elevated inflammatory markers such as nitric oxide. And what you see is that not everybody has all of these. You can have one or more of these factors. And it probably argues that the disease is expressing itself differently and therefore is probably differentially responsive to the types of therapy we throw at it. So, as part of the original SARP, we did what was called an unsupervised cluster analysis, a statistical approach where we didn't go in with any of our preconceived notions, and we wanted to see if there were a variety of asthma-related factors that grouped patients together based on their similarities. And what we found is that there are really 4 such groups within childhood asthma, not just severe asthma, but childhood asthma in a broader sense. And in that red box on the right, what you see are a collection of the types of features that we looked at to help to define these clusters. But as you see on the next slide, most of this really was based on 2 disease aspects. Lung function on the vertical axis and duration of disease on the horizontal. And what we saw is that there's a first cluster, which has well-preserved lung function, later onset, and therefore shorter duration, with symptomatic asthma. There's a second cluster that has a slightly longer duration, and therefore an earlier onset of disease. Tends to be atopic, but also with preserved lung function. There's a group with very early onset disease whose airflow limitation is a bit more compromised. That's cluster 3. I just go over it. All right. And then there's cluster 4, which is probably the most severe of the 4 clusters. These are folks who have early onset atopic asthma with advanced airflow limitation. So these are 4 distinct groups found by statistical methods that we wouldn't necessarily have guessed in advance. But what you see on the next few slides is how they differ based on symptom burden and other disease features. So as you see, as the cluster number increases, and therefore as the quote-unquote severity increases, the average number of oral steroid bursts goes up on the left. The average daily dose of inhaled corticosteroid for maintenance goes up on the right. On the next slide, we see that there's also a tendency toward greater atopy as you move from clusters 1 through 4 with more. Hey, that was almost familiar.
trying to get both of them to work.
Okay. So there's a trend. If I could just. Oh, we're going to get it again. We're so close. I just want you to get this close.
While he's fiddling here, just looking at these clusters,
I think I'm at the top.
Yes.
are these really enough different statistically that you can really segregate them into these four clusters? They look like the means are not that dramatically different.
The means are not that different. But, if you look at the extremes of the means, you see that they are. So, as an even gradation, not as much. But if you look at the far, the leftmost and the rightmost, they tend to be
Statistically different.
Yeah. We don't spend a lot of time doing those comparisons. This is more of a descriptive rather than a sort of statistical. Yes.
Within this study, because you said just beforehand, there's the difficult to treat, relatively non-compliant versus the true severe. Was this study separating those out, or is one of these clusters predominantly individuals who are...
No, so we did not attempt to categorize them as we did in APIC. It's difficult to treat and not difficult to treat. This is the entire pediatric population that got there through their own pathway, whether they're difficult to treat or severe disease. We believe that the bulk of them have true severe asthma more so than simple difficult to treat asthma. It's fine.
Well, okay, if you was, I can't see what's wrong with that. Let's flip it around for you.
Can you advance the slide?
Just right up at the top, there's a swap display.
Yeah.
Just click that.
Yeah, I can see it. Okay. Try to get it up here. And right there.
How
There we go.
for a cheese. All right.
Are we broadcasting it too?
Yeah, broadcast.
All righty. So, and then, if we look at lung function, we see that there's a clear relationship between cluster assignment and FEV1 as an indicator of airflow obstruction and RVTLC as an indicator of air traffic. So as we move through these cluster assignments, you see that they do indeed show us a spectrum of severe disease in children. But if you then try to...
Oh.
But we've given this man more grief. He gets a bigger honorarium.
You got to scroll off the page.
You got to turn the Wi-Fi off.
Travis, don't leave the room.
I haven't gone anywhere yet. I can't get that.
All right, we are so close.
Move it off the screen.
We still have the images in front of us if you want to move along.
Try.
Yeah. I mean, forget the screen.
All right. So what's interesting about this next slide that's behind me, so we then attempted to relate cluster assignment to asthma severity as the guidelines would assign. And what you see is that these cluster assignments don't clearly relate to guideline level severity. Okay? So there are patients who have mild persistent asthma who are in cluster 1, and there are patients who have mild persistent asthma who are in cluster 4. So just because you're in cluster 4 doesn't mean that we would look at you in clinical practice and say you have severe disease. Similarly, there are patients, the severe persistent asthma tends to land in clusters 3 and 4, But the mild has features that might spread across all of these clusters, telling us that there's a remarkable amount of heterogeneity that underlies all that is this population. So I think there's one of these is out of order, but we'll get to this. This is almost a throwaway point, but I want folks to have an appreciation of. We talk about racial disparities in asthma all the time, as if we understand what that is. And we all say that having severe asthma is more common in African Americans, they have greater disease morbidity, they have all these other features, and we believe that that indicates a racial disparity, which it does. But what Ann Fitzpatrick has helped us see is that if we really adjust for many other relevant factors, such as those that help define community, socioeconomics, and environmental exposures, many of those disparities go away. So it isn't purely race that's there. That these are indeed related to other factors for which race is a surrogate, but isn't exactly the most precise. So this is work that came out of the Childhood Asthma Management Program. And what's here is a reminder that asthma in childhood is a disorder of progressive worsening of lung function in the majority of patients. It happens slowly in some, but it can be quite substantial. And that even among children who had mild to moderate asthma in the early school age years, there's still a decline in lung function. And 3/4 of these children have evidence of either what we call reduced growth or reduced growth with or without early decline in lung function. So there's a decline in lung function that occurs even in mild to moderate, reasonably treated asthma. And among severe, this is certain to be magnified. And many of these children, by early adulthood, meet diagnostic criteria for COPD despite no smoking and having had asthma, recognized early in childhood and managed appropriately. So it's just a reminder of long-term consequences of even mild to moderate childhood asthma. So another element of childhood asthma that I want us to keep in mind is this exacerbation prone phenotype. These patients who come to us because they have multiple exacerbations per year. So in the third iteration of SARP, Lauren Denglinger led us through this analysis where we tried to understand what might be different between the frequent exacerbator and the non-frequent exacerbator. So both the adults and the children who entered SARP had a median of 1 exacerbation in the prior year. 40% had none, 35% had 1 to 2, but a quarter had 3 or more in the past year. And what he did was try to understand what differentiated those who have exacerbation-prone disease from the others. And we did this both separately in children and in adults. And if you look at exacerbations in the last year in the left-hand panel, the pediatric folks are shaded in that horribly ugly green. What you see is that there is a positive relationship between the amount of albuterol response that they had at baseline and the number of exacerbations. So greater bronchodilator reversibility is associated with more exacerbations. It's an indicator of that phenotype. It just tells us there's airway lability and they sit at a higher level of airflow obstruction and therefore probably more susceptible. However, if you look at blood eosinophils, the biomarker of choice now, the one that drives much of our biologic choice, what we saw is there was no relationship in these children between blood eosinophils and their number of exacerbations in the past year. It was almost significant in adults, but it wasn't significant in children. So while dilator response is a related factor, eosinophils are not. What about IgE? The children, as you would expect, had higher total IgEs than the adults, but there was no significant relationship between the total IgE level and the number of exacerbations in the past year. So this is not a marker for exacerbation-prone disease in children, but it is in adults. In adults, there's a very strong inverse relationship. Yes, inverse relationship. The higher your IgE, the lower the number of exacerbations. It makes no inherent sense, but it's highly significant. That blue line is really quite impressive. But in children, there's no such relationship. It's kind of opposite what one might have thought, both in terms of the child versus adult and the direction. But it is what it is.
Is that telling us in adults it's really a different type of asthma that is often, it's not allergic?
There are. I mean, I think what it's telling us is that these, but remember, there's a selection bias here too. But it's telling us that the adults who had the most exacerbations have the lowest IgE. Maybe. I don't know what that means. I mean, I really don't know what it means other than.
Well, clinically, we've always, at least I've always felt that what we called adult onset non-allergic asthma are the most difficult patients. So in that clinical sense, it makes sense. Were these people tested for atopic?
They were.
Were they atopic, the adults? Or
Many.
the less atopic they were, the more exacerbation problem?
A little bit.
Yeah, that's what you see in real world clinic.
Exactly.
On this, it looked like a small subset were on Omalizumab.
Yes.
What effect did that have on that relationship?
We pulled them out because we didn't trust their IgE levels.
Oh, so they were not part of
Yeah, so they were pulled out of the analysis. Yeah, because you can't accurately measure their IgE. All right. So what about lung function? So this is pretty clear both in adults and in children. The exacerbation-prone patients have lower lung function, at least as reflected by percent predicted FEV1, than did those who have less frequent exacerbations. But as those of us who care for children know well, very few children actually have low lung function despite having severe disease. Only 22% had an FEV1 less than 80% predicted, and only 3% had an FEV1 less than 60%. That's in contrast to the majority of adults who had an FEV1 less than 8, and a quarter who were less than 60. So again, childhood asthma preserves lung function even in the most severe state, but there clearly is a difference between the exacerbation-prone group and the minimally exacerbated group. So a third aspect of the SARP that I think is worth pointing out is corticosteroid responsiveness, and what does that teach us? We view most of our patients as corticosteroid sensitive. We think that when they're not doing well on inhaled steroids, it's because they're not taking it rather than the drug doesn't work. We don't trust them. We're doubtful of their adherence. So many times in clinical practice, folks have resorted to IM triamcinolone as a bridge to gaining control, maybe minimizing side effects. We thought we would try to characterize steroid responsiveness in a group of severe asthmatics, taking adherence out of the equation by giving all of them an IM injection of triamcinolone when they entered the program, and measuring a variety of pre-post factors to determine what response these severe asthmatics had to triamcinolone. So we did this 1 milligram per kilogram up to 40 milligrams. We did it in both our patients who had severe and non-severe asthma, and reassessed them 15 to 21 days later to see what we were able to accomplish with a known exposure to IM triamcinolone. And what you see in the first slide that says airway function. Did these make sense?
Yeah, we got it.
That IM triamcinolone improved airway function in adults pretty substantially, pre-bronchodilator and post-bronchodilator, in both severe asthma and non-severe asthma. But in children, there actually wasn't much of a change. And the children on the far right two panels, what you see is a non-significant improvement pre to post in the severes, no change in the non-severes. Pre-bronchodilator and post-bronchodilator, they're about the same. So we really didn't budge their lung function for the most part. A small proportion had an effect, but the majority actually did not improve their lung function as it relates to triamcinolone.
But the lung function was pretty good. It was hard to improve.
It was hard to improve, but they still have difficult to manage disease. These are patients who showed up with a lot of morbidity to them, and there isn't lung function to improve. But I think those are fair points. But let's look at some other things. Let's look at airway inflammation. So on the left is pheno, on the right is bloody eosinophils. And what should have happened, right? You give IM triamcinolone and you reduce airway eosinophilia, or you reduce blood eosinophilia, and you reduce pheno in all of the patient subgroups. Whether you're severe or non-severe, whether you're a child or an adult, whether it's, all of these improved with this. So it does indeed alter airway inflammation. Its effect on lung function was inconsistent. In the adults, we did sputum analysis and showed that we reduced airway eosinophilia. In children, they wouldn't do the sputum well enough, so we don't have those data. So unfortunately, I can't tell you what would have happened there had we done that. But let's look at symptoms. Okay? This is why our patients come to us. If you look at their asthma control questionnaire 6 score, before and after triamcinolone, you see that in adults, both in severe and non-severe disease, there's a significant reduction. And in the pediatric severe, there's a significant reduction. So it does indeed improve the symptom burden just over that 2 to 3 week period. But it does it without a change in lung function and with an improvement in airway eosinophilia. So I'm just trying to make up a little bit of time here, so I'm going to selectively skip a little bit. So I'm going to move on to the slide called Approach to Difficult to Treat Asthma. And this is really where clinically we have to start differentiating between patients who have difficult to treat disease and severe therapy-resistant disease, because our clinical strategies should be different for those patients. We want to look at adherence, we want to look at environment, we want to look at psychosocial issues, barriers to care, co-morbidities, allergy, lung function, airway structure, inflammation, and their ability to respond to steroids. Because we are going to approach these patients in a slightly different way. We need to remember that there are differential diagnoses at work here, and this doesn't need a detailed refresher on that. But I think it's important for us to remember that not all asthma is really asthma. And just because it was asthma once doesn't mean it's asthma now. Doesn't mean that because you have difficult to treat disease is because of inadequate asthma therapy. Other diseases show up, other conditions show up. And if we don't continually re-explore differential diagnosis, we are going to not do our patients the best service. We need to address their comorbidities. These are the ones that people talk about a lot. And there's reason to believe they certainly coexist with asthma. I do think we are in a slightly evidence-free zone as to whether treatment of these consistently improves asthma care. The data on reflux and asthma is not as clean as one would hope. Obesity, there's a relationship there, but that management is not so straightforward. Sleep apnea coexists with asthma, but we've not seen a whole lot of evidence that once you treat their sleep apnea, their asthma gets better. It's another condition, and it confuses them at night. But it isn't so clear that by treating these comorbidities, you can fix the asthma side of things. Sinus disease has a checkered history around this area as well. And depression and anxiety is probably underestimated and underaddressed. It probably does contribute. And that's probably the one of these comorbidities that we look for the least and might actually be able to improve the most. So I think it's really important for us to keep that side of things in mind. The majority of difficult to treat asthma is non-adherence. There are lots of ways to be non-adherent. Some of them are intentional, some of them are non-intentional. Inhalers are complicated devices. Our patients have identified multiple interesting ways to use inhalers, none of them better than the intended, and some of them highly maladaptive and result in poor drug deposition, poor drug delivery, and therefore poor outcomes. So I think it's really important that we don't take any of these other factors for granted. But again, adherence is complicated. There are lots of studies now looking at electronic devices and reminders and all these other things, and they're pretty inconsistent in their ability to show that they improve asthma. You can show that you can improve adherence, but how much do you have to improve adherence before asthma gets better? If you take somebody from 40% adherence and move them to 50, you improve their adherence. But did that 50 improve their asthma control? It's like dust reduction, right? You can reduce it a little and it probably doesn't do very much. If you can't reduce it enough, you probably won't have the clinical impact that you want. So even all these nice strategies that are coming out, these electronic devices, they're going to help us, but none of them are going to fix the problem entirely because none of them get you all the way. So this one, you'll be able to at least see something. So this is our algorithm in our severe asthma clinic, where we work through all of these factors in a sequential manner in an effort to assure that we have addressed all elements of asthma care in these patients. So we ask, first of all, if they're controlled. And if by some miraculous situation they're well controlled, we think about stepping down. But that's hardly ever the case. We usually start from an uncontrolled state, and we ask if they're on maximal therapy. And if they're not on maximal therapy, we ask whether they were adherent to whatever therapy they're trying to give them, and if so, we will step them up after a confirmation of asthma. Okay? But if they're not adherent, where do we go from that? We try to understand why they're not adherent. We say that we do this by addressing and assessing barriers. We look for economic ones, such as co-pays and inability to get to medical care. We look at their health beliefs in terms of whether they believe their child has asthma, whether they believe the therapies are effective, whether they believe the therapies are safe. If they don't believe the therapies are necessary, safe, and effective, they don't use them, and the children don't get better. We ask about social factors such as school and peer support. We ask about family dynamics. Family conflict is a great way to uncouple asthma control, and we really need to address this, because if we don't, everything else we do is a waste of time. And we need to look at health literacy. We give them these complicated asthma action plans. That's really unfortunate when you give it to people who either have problems with standard literacy, or they really don't understand the health communication that we're trying to share, and we really want to improve their knowledge. We want to give them action plans they can understand. We have them without words. We have them with simple, colorful pictures that really help, because I think these are things that we often overlook, and that patients and parents are unlikely to tell you. I've never had a mother or a father look at me and say, I can't read. But I know a lot of them can't read, and they can't read what we give them, but they've spent a lifetime faking it, and they're pretty good. So I've never had somebody admit it, but I know it's out there. And if we don't think about it, if we don't try to understand it, we'll never do better. If they're on maximal therapy, we want to again reassess adherence, and if they're not, reassess barriers. If they're adherent, we look for co-morbidities. We already went through that list. And we reassess a differential diagnosis. And once we have that, we have a starting point. And then at every visit, we try to spiral back through this thought process, because we really want to be confident that we're delivering care that is appropriate and effective, so that these children have minimal impact in life. All right. So let's talk about treatment. I'm going to do this in the setting of a boy that we saw last year. And this one's a little different than most case histories that you're going to hear. Right? So this is a 5-year-old boy who's had asthma since age 2, symptoms since infancy. So diagnosed after a year and a half of clearly having asthma. Has an exacerbation at least once a month, coughs every day, clearly more symptomatic with activity, wakes at night 1 to 2 times a week, 5 hospitalizations per year, and miraculously none that required ICU care to date. His baseline therapy was budesonide plus high-dose ICS LABA, initially mometasone formoterol 100, then increased to 200, receives montelukast, loratadine, and intranasal fluticasone. He's got allergic rhinitis and evidence of allergic sensitization by skin tests. He has sleep apnea as defined by an abdominal polysomnogram, and we're teeing him up to OCENT. We did not identify risk for depression in him or the family, and we didn't find any evidence that supported concomitant gastroesophageal is a 5-year-old. His lung function was atrocious. He had a pre-bronchodilator FVC, 63% predicted, but he had a remarkable 59% improvement with bronchodilation and still remained obstructed. He, despite being a really good spirometry candidate, he was no good at doing pheno. He had a negative sweat chloride. We did a CT of his chest. There was a little bit of bronchial thickening, but nothing else diagnostic. I had one of my pulmonary colleagues do a bronchoscopy in BAL to evaluate anatomy and for infection. There really wasn't much there, a little bit of secretions. We found some varicella that gave him a course of ceftonate that didn't do anything for him. We gave him, he had phenotyping that showed a total blood eosinophil count a little over 1,000, total IgE of 4,700, multiple positive skin tests to seasonal perennial allergens. He receives Missouri Medicaid, so we have an online way to check his prescription refills. And his mother was doing really, really well. Refilled 10 out of 12 ICS controls. His inhaler technique was good, so we really don't think that this is primary non-adherence, although I'll tell you, that's where we started. But the data, just because you pick it up from the pharmacy doesn't mean you take it. But she was going out of her way to try to convince us he was taking it, so we probably think that he was actually taking the medicines. They didn't doubt asthma as a diagnosis. They trusted the therapy. They trusted the care team. And we really couldn't identify any barriers other than this child just had very difficult to control asthma. So when we look at the GINA strategy for the management of moderate to severe disease, it's complicated, right? It's medium to high dose ICS plus add-on therapy. And, I think it's important, especially for the fellows, to realize that when we talk high-dose inhaled steroid in children, the numbers are different. It doesn't take a whole lot of inhaled steroid to get into the high-dose range. And this boy, being on 400 mics a day of mometasone, was indeed getting high-dose therapy. This is for ages 6 to 11. Remember, he's 5, so this is actually very high-dose ICS therapy. So just because it's 400 a day doesn't mean it's a non-trivial dose. The problem with inhaled steroids, we all know, is that the dose response is inconsistent and nonlinear. Little response in general to increasing the dose of ICS beyond moderate dose, but there are some children who seem to have that response, and that's what we do. It's unclear whether small particles alone or in addition to conventional inhalers are more effective. We didn't want to go there. We thought it added complexity. And it's very clear that there's a risk of adrenal suppression and growth retardation that are dose and duration dependent. So we don't want to just indiscriminately increase our dose. I think we'll skip over the ICS lava safety stuff because I think you guys know those data quite well. And I think the only point to be taken away is that in the pediatric study of ICS lava safety, it actually didn't show a statistically significant protective effect for exacerbations with the addition of LABA on top of ICS. Don't really understand why that was. It was a plenty big study, but the hazard ratio there didn't be statistical significance. Yes, sir.
Did you ever think to do the injectable steroid in this child for 6 or 8 weeks and see if it made a difference?
We thought about it. That one the family wasn't terribly excited about. And again, the question is, what are we trying to learn from that? We tend to do that when we think they're being non-adherent. And we didn't have reason to think when he was on steroids, he actually did okay. But we felt that was a level of toxicity we really wanted to do our best to avoid. Oral steroids are the enemy. We had dinner with last night, but he said they're the enemy now in 2019. We're using these to manage the disease. I don't think we're doing the best by our patients. There's really a small proportion of children who need chronic oral steroids. At the moment in our program, we have one child who's on transient oral steroids, so we try to get a biologic approved. But I think it's a pretty rare situation. Tiotropium has some added value. The data really support more of its ability to reduce or improve lung function and reduce exacerbations. Biologics, I'll talk a little bit about what we know about them in children because we don't know enough. Omalizumab is the one best studied. These are studies that we did as part of the Inner City Asthma Consortium. Omalizumab given to inner city children when added to guideline therapy is highly effective in reducing exacerbations. These children experience a near complete elimination of the seasonal bumps that related to viral infections. So an anti-IgE therapy preventing viral trigger disease. Kind of an interesting concept. I don't know that 15 years ago when we got omalizumab in our hands, we thought that's what the target was. We figured it was a heart disease. But it really also seems to improve viral trigger disease. We also studied short-term omalizumab, in that we know that these children are experiencing fall-time exacerbations, and therefore we wanted to see if giving them omalizumab just before they returned to school and just during the fall would have an effect on exacerbations, and it did just that. It reduced severe exacerbations in children, but it really did so among children who had the most severe disease, those who needed a step 5 therapy, high-dose ICS-LABA. If you were on less than that, it actually didn't seem to be any better than leaving their therapy alone. But even a short course of omalizumab through the fall on school return was effective in preventing the most exacerbation-prone children from having exacerbations. This is a summary of the approved biologics for asthma. I'm not going to go through this in any detail. I think the point here is that we have choices. We don't understand how to make the right choice. We don't understand who benefits from A, who benefits from B, who would benefit from B over A in an individual patient. We just aren't there. I wish we were. I wish we had a sensitive, specific biomarker or clinical situation that helped us identify which patients are going to derive greatest response from which agent. The point I want to leave you with is this concept that we know hardly anything about these drugs in children. I did not include the omalizumab because that's the one that we have actual childhood data on. But if you combine the other 4 biologics for asthma, there are 265 treated children. In all the studies, in all the published trials, for all 4 of those agents combined, and a lot of them got placebo, so it's not like they got active therapy. So we really don't have a great sense as to the most appropriate, most effective therapy. I think we've got some of these studies ongoing. Many of these are now actively being studied. But as of today, we are limited in the evidence that helps us decide amongst biologics for children. So I want to bring this case sort of back to the concept of phenotyping, because we felt that this boy needed something more than what we were doing. He's 5, so he's off-label therapy. We felt we needed to do something. He had an eosinophil count of a little over 1,000. He had a total IgE of 4,700, and he had sensitization to multiple allergens. So we made the clinical decision to start omalizumab. So we wrote a prescription and we went through the prior auth process. And 4 weeks later, while we were waiting for him, he had a cardiac arrest. He woke up with asthma symptoms, got 3 albuterol treatments. 4 hours later, got a little bit more. Went to a birthday party and struggled through that. He did some albuterol there, went to the emergency department. Lost consciousness en route, received resuscitative efforts, was transferred to the ICU. 10 days later, it was clear that nothing recoverable was in front of us. He had severe hypoxic ischemia, brain injury from the following day. The family made the very difficult decision to terminally estimate. Okay. This is not how most of these cases end, right? These end with, we started him on X, and his life got better. We don't know what would have happened because he never got a dose, because we were still waiting. That's at state system. Whether it would have changed his outcome or not, we don't know. He has horribly uncontrolled disease, horribly labile disease. Why this exacerbation was so much worse than everything else, we don't know. But I think it reminds us that not all of our patients who have severe, difficult asthma are non-adherent. Some of them have this horribly labile disease that needs all hands on deck, that needs early consideration of additive therapies in an effort to really try to save these children's lives. In St. Louis, this unfortunately was the 5th child in 2 years who died from asthma, which is something I've never seen. My mentor and colleague Bob Strunk, when he moved to St. Louis, encountered this same sort of phenomenon, this epidemic of asthma deaths, and wrote a classic series of papers that help us all identify fatality-prone asthma. The problem is this child doesn't meet any of his criteria. Never been in the ICU, never been intubated, didn't have family dysfunction, didn't have adherence, didn't have depression, didn't have anything other than screaming at us that, hey, I have really pretty difficult asthma. And all those prednisone courses probably are an indicator that I need more. So what I hope we've accomplished, and I apologize for going at near warp speed, is that severe asthma is about 5 to 10% of childhood asthma. It's really associated with substantial morbidity and healthcare utilization. There are comorbidities and diagnosis confirmation that we need to do on an ongoing basis, not just at initial evaluation. This is a disorder associated with multiple barriers of care and adherence issues, and that's where we got to spend more effort than I think collectively we've historically done. So we need to think about phenotyping. I think we wait till the disease is too severe before we try to do phenotype-directed therapy. I think we need to get the right therapies to the right patients at the right time. We need more pediatric-focused research and have to stop relying on our extrapolation from adult stuff. And unfortunately, there are still children dying from asthma in 2019 in the United States, which to me is a horrible situation that we find ourselves in. And I hope we can do better. Hopefully it's work like this and our greater understanding of where the disease is coming from to use our better therapies to improve it. So I'll stop there.
Was there an autopsy in that kid? I'm wondering if he had eosinophils in his myocardium and had more like hypereosinophilic syndrome.
The family had enough. They did not consent for an
You mentioned like lots of distinction between pediatric and adult asthma. What's like the background? What's like the basis beyond the difference in terms of like blood eosinophilia and exacerbations, IgE? And is there any explanation or just like an observation on studies?
I think asthma is a heterogeneous disorder, right? Somebody whose disease starts in their 40s has got to be something different than someone around this one who started, in the first year of life. I think we see that the disease manifests itself differently. I think adults have a much higher rate of non-allergic, non-eosinophilic disease that we call asthma for lack of a better term. Whether it's really the same disease is debatable. I mean, if we call airway hyperresponsiveness the constant, and if airway hyperresponsiveness is asthma, then it's asthma. But the inflammatory patterns couldn't be more different. They look completely different. Where else in medicine do we have such disparate inflammatory processes, yet we call it the same disease? And we expect it to respond to the same therapies. It just is inconsistent. I just think we're stuck with this terrible, broad umbrella term of asthma. And we throw so many things under that umbrella, trying to say they're the same. And I think now we're getting to the point where at least we're realizing there are different flavors of asthma. Maybe once we really understand this T2 low disease, maybe we're going to call that something else. We can really understand what makes it different. Maybe the best way to treat it is to rename it so that it has a different treatment paradigm to it. I don't think we understand why the age effect is as impressive as it is, but it really speaks to the necessity of having these studies in all the age groups to help us identify and treat them appropriately, because adult-derived data really don't get you the insight you need to treat children and vice versa.
When you look at kids like this and you have your list of alternative diagnoses, do you make sure that you've excluded everything on that list before you call them difficult to treat childhood asthma?
As many as seem reasonable. I mean, you need to, keep a clinical eye toward it. I mean, if the child doesn't have ear disease and sinus disease, he probably doesn't have PCP. He probably doesn't need a ciliary evaluation. But yes, even if they have no clinical evidence of reflux, we're going to think about these things because it would be horrible to miss a treatable condition and increase our asthma, quote-unquote, toxic therapies when we had some other path to go. So I think most kids who are going to present to this level are going to get this in-depth an evaluation. That's not to say everybody who presents with asthma needs it. It needs to be targeted, it needs to be thoughtful, and not just blind. But I do think that sometimes you gotta be complete because we've all seen it. I mean, we've all seen children who present with a lifetime of asthma who had something else. I think presented with a lifetime of asthma. So we found a vascular ring and took care of it at age 8. She didn't have asthma no more. I mean, should I go looking for an anatomic abnormality in an 8-year-old? Glad I did. We found it and she got much better after a surgeon relieved that compression. So I think we do need to keep these things in mind. There's always a differential. We're never done.
I was just curious whether you think bronchiectasis, bronchopulmonary dysplasia, and bronchiolitis obliterans, can you diagnose them with chest CT, or do you need to actually bronchoscope those kids?
I think almost all of those can be diagnosed with CT. Okay. Bronchoscopy, I think, helps you identify airway anatomy that is dynamic. So it helps you identify malacia that you can't always see on the CT. It helps you look for a cold infection, which sometimes you find, and the younger the child, the more likely you are to find some form of a cold infection that you might treat. It allows you to get a characterization of their airway inflammation. Every now and again, you go down there and you find a peanut. And you solve the problem. So I think we tend to be a little slow in doing airway exams in these young, persistently wheezing children who need a lot of therapy. I'm a big fan of looking down there because you just gotta know, because we're wasting our time giving them more inhaled steroid when they need is 3 weeks of antibiotics. So I think we just gotta keep replaying that theme in our heads.
The comment here, ongoing research is critical. It strikes me, and don't take this the wrong way, that phenotyping has sort of gone as far as it can in defining the different types of disease. You see some new genetic marker, biomarker in the future that's going to make this much easier to segregate who's going to respond to what.
I don't know, Matt, what do you think?
It's obviously where people are looking. I mean, I think it's molecular differences, right?
Yeah. Do we have something promising?
I don't know. You can come to my Quad AI talk and see.
Oh, that was hard. You're his dad.
I'm telling you. Is it a short chapter or long?
I said you're going to be that elusive.
Well, no, I mean, the answer is we have the biomarkers we have right now, IgE, pheno, and eosinophils. But there's a lot of active research trying to define others.
Yeah, I think it's where we are. I think those are widely available. They're cheap. They're reproducible, and in doing so, they're not that good. I mean, they're pretty non-specific. Fortunately, they're giving us some clues. They're helping direct some therapies pretty well, but we're far from having a perfect biomarker. But I think we'll get there. I think this metabolome is trying to. We're going to find some indicators that really help define the disease better than what we're doing.
Well, thanks for putting up with that.
Thanks for jumping around. Thanks for
Wabash.
You don't see that with a lot of
Better.
Yeah.
So,
Did they, I forgot to ask, did they have any others
SARP is doing.
Oh, we did connect, yeah. We had 2 patients come, but there was a bunch of yeah, but a bunch of I had spoken to them. I wanted to go canceling and they were going to show up, and my commute time would be 6 hours. 6 hours? Yeah, previous week it took 2 hours to go. I was coming from.
Well, I don't know that I don't think
I don't
is
know,
that
the
part of
buses were
inner
like
city yet?
great. I usually don't
No,
do stuff.
no,
But they were going like every 10 minutes. I think because of the snow, they were being like extra. I don't know. They were like
maybe since it's Seattle, they cleared off the snow faster. I think they were progress. The bus was cancelled. The previous week there was buses running.
for the meeting? What about the,
there were no buses. He had to walk.
those questions with general?
So I think it just depends on like where you are.
No, the previous week, the first time it was snowing, I was still able to take the bus.
So I told,
But the following week it was cancelled.
Yeah.
Where are you going?
today?
And it's risky to come on Uber also.
Yeah.
They're still sending.
I could take it down to Renton.
Yeah, actually, on my way back from the surf, it really.
I mean, I also.
Right, that's when it started to snow.
Very hard, yes. It's like, oh my god.
Yeah.
I don't know if it's a good idea to keep it. That's why, you know, for you guys actually, went up to the distance.
Well, it was better though, because then I didn't have to go in at like 7 o'clock. You know, at least.
oh, okay, because the, him himself from.
No, that's what I was like, yeah.
Well, I think that's probably second.
Yeah. Was there anything else you wanted to explore with them? You got so much going on.
Yeah, I mean, we gotta finish this.
Is that phone call happening today?
You know, I never got any follow-up on that, did you?
I have to go down to Renton and work on that, so I can't really participate in it. You know, Matt, is that happening?
Well, wait, Ramon emailed us back, but probably not.
I haven't seen any response.
Our job is also to print all this out.
Oh, okay. I haven't read on this. It was interesting, the amount of lung function improvement. Did they actually solve this?
Thank you for all your help.
All right, sorry we gave you guys such frustration this morning.
Oh,
Why
geez,
do
no
we
problem.
Biologics?
It worked.
What, did you see it on the screen? Was that thing in the center on the screen?
No, so he had it on filming.
Can't forget the
He
Yeti.
had this circuit projection and also had
So you saw screen images and you could hear them well? So we had an outside audience.
We did.
So we broadcast.
Yeah, we did broadcast.
Okay.
It took a while to get this. Once they got it up, it was fine.
We definitely see
All right.
practice. Like,
Wait.